the management of coronary dissections occurring during DCB PCI. These are my conflicts of interest. So as you all know, coronary dissection during DCB PCI are common, and visible angiographically visible dissection are found in up to 60% of patients. We all know that spontaneous healing of coronary dissection is observed in the vast majority of patients undergoing DCB PCI for de novo lesion. But despite this, coronary dissection remains the primary reason for bailout stenting during DCB PCI, and this occurs in 5 to 22% of patients in most recent major DCB trials. Therefore, optimal strategies to manage coronary artery dissection during DCB PCI are essential for expanding the adoption of this strategy. The strategies aimed to manage coronary artery dissection during PCI with drug-coated balloons are mainly relying on three pillars. The first one is to prevent the occurrence of these complications, if we can call them complications, we'll see. Second is to recognize those lesions that deserve treatment compared to those that can be left untreated. And finally is to assess how to manage these flow or limiting coronary artery dissections. So let's see what we know from observational studies. There's a lot of these retrospective observational studies trying to identify predictors of coronary artery dissection occurring during DCB PCI. With women, a higher DCB to reference vessel ratio, longer lesions, and LAD disease, identify, among others, predictors of the occurrence of coronary artery dissections. But I think that beyond clinical and angiographic characteristic, we have to acknowledge that coronary dissections are an inherent part of DCB PCI that may result from either or both lesion preparation and DCB balloon inflation. Therefore, at this stage, it's important here to highlight some important procedural aspects in DCB PCI that should be followed in order to prevent the occurrence of coronary dissections. The first one is using a 1-to-1 balloon-to-artery ratio based on distal reference vessel diameter, and this is for semi-compliant, non-compliant balloons in order to prepare the lesion, but as well for the DCB that will be used to treat the vessel. We already discussed, and some previous speakers have discussed on the emerging role of scoring balloon in DCB PCI, and here I want to highlight that it's an emerging tool not only for lesion preparation and obtain lumen gain, but as well in order to prevent the occurrence of flow-limiting coronary artery dissections. And this is a nice study by Professor Shin, published a few years ago, showing that the use of scoring balloons in DCB PCI of de novo coronary artery lesions increases the rate of type B, A and B coronary dissections, while improving lumen gain as well as achieving optimal angiographic results compared to the absence of usage of this scoring balloon. And scoring balloon is the only predictor of occurrence of type less than C, sorry for the typo here, coronary dissection occurring during DCB PCI. So therefore, I think that scoring balloons enable a more controlled coronary artery dissection and should be part of most of these procedures when available. When using a scoring balloon, size is important, and I like to come back to this experimental study from a Chinese team published a few years ago, showing that downsizing the cutting balloon by 0.25 or 0.5 millimeters actually allows to achieve the same maximal value of the maximal principal tensile stress in an artery model when compared to a 1-to-1 non-compliant balloon inflated at high pressure. And therefore, by downsizing the cutting balloon, we may reduce the risk of severe dissections and perforation that may complicate these procedures. One point that deserves some attention is the duration of the DCB inflation time, of the DCB inflation, and this is something that comes from the POBA area, and we know that prolonged inflations are meant to seal the dissection occurring after POBA. Here we have nice data from the Eastbourne registry looking at long, more than 30 seconds compared to shorter balloon inflation time, showing that prolonged DCB inflation time aims at reducing the rate of bailout implantation while achieving a better TIMI flow at the end of the procedure, despite the fact that this does not translate into improved clinical outcomes. So here it's important to highlight some more procedural aspects related to long inflations, probably more than 30 seconds for the predilation and 60 seconds for the DCB, and the need probably to undersize the cutting balloon in order to prevent the occurrence of complications like dissections. We already touched the point of intravascular imaging that may be helpful in some cases to assess cell vessel size and optimize the DCB size, again, in order to reduce the occurrence of coronary dissections. So we all know that the assessment of a coronary artery dissection occurring during DCB PCI has been historically and based on the data from the POBA area, based on an angiographic classification that has been proposed more than 50 years ago and which was not developed in the field of DCB PCI. Based on these classifications, we assume that type A and B dissections are considered safe to leave, whereas type C dissection are more open to debate based on this only classification. When applied to a large cohort of patients and going DCB PCI for de novo lesion, and this comes from a group from Antonio Colombo, we see that most of the dissection occurring during DCB PCI are type A and B dissection, and those do not translate to high rates of bailout stenting, suggesting, as said, that these make quite safe lesions, coronary dissections to leave, while the others, being less frequent, are associated with higher rates of bailout stenting. One of the major advances over the last year has been the recognition that coronary dissections are not only bad, and when left untreated, they are associated with good angiographic outcomes, as shown here in this study of 227 patients, highlighting that the presence of beyond angiographic appearance, but considering flow of type AC non-flow limiting dissections, irrespective of its severity, included type C, as you can see here on the right side, are not associated with worse clinical outcomes. And this translates into several series of patient cohorts treated for de novo coronary artery disease with a PCB into similar clinical outcomes at 2 years. And as you can see on the right side, similar target lesion failure rates at 2 years when the dissections are left untreated when compared to those who do not present with coronary dissections. More recently, in the ears-bone registries, these findings were translated as well in patients that were treated with a sirolimus-coated balloon. And as you can see numerically here, lower rates of clinical outcomes at 1 year. So overall, these data suggest that non-flow limiting dissections, irrespective of the angiographic appearance, after successful DCB PCI, are not associated with worse clinical outcomes. And this has evolved the concept from an angiographic classification to probably a more subtle classification of safe-to-leave dissection that integrate not only angiographic appearance, but as well the TIMI flow, as you can see here, and probably as well some ECG patterns and patient symptoms. So based on this contemporary evidence, I think that, and this is open to debate for sure, that types A and B, as well as selected non-flow limiting type C coronary dissections, are maybe probably safe to leave untreated without any additional stent. And this has been suggested here by the group of Antonio Colombo in this flow chart, suggesting that the absence of extraluminal contrast hang-up and a TIMI flow of more than 3 is an acceptable result for DCB PCI and prevents from using bailout stenting with a drug-eluting stent. We already discussed the potential interest in using coronary physiology in those lesions that have A, B, or C coronary artery dissection to assess flow. And we can see here in this nice registry from the team of Antonio Colombo, reduced stent, showing that when using a cutoff of 0.90 of PDPA in lesions with type A and B coronary dissections, this leads to a significant reduction in the burden of metal implanted in these patients, either alone or as part of an hybrid PCI strategy, with more than 70 patients treated with a drug-coated balloon. However, we have here to highlight that we do not have evidence-based thresholds available for these physiologic assessments, including for FFR or even for the emergent QFR, and dedicated randomized clinical trials are definitely needed in the future. So how to manage these coronary artery dissections? So we all know that at 6 months, the vast majority of coronary dissections heal spontaneously, and this has been shown quite consistently across several cohort studies. But what is probably emerging over the last year is that coronary artery dissections are not always bad. And probably medial dissections are shown here in a nice study, only 83 patients, when associated with an ARC of more than 90% are associated or are independent predictors of late lumen enlargement. So this is probably part of the benefits of drug-coating balloon in achieving this kind of dissection that should be left untreated to facilitate transfer of the drug to the vessel wall. This has been extended in a more recent trial. 328 patients who underwent OCT assessment after DCB PCI. As we can see, more than half of dissection involved the media. And these are associated with a reduced probability of target lesion failure independently of the presence of calcium at the site of the DCB treatment. One emerging evidence as well is the concept of dissection volume, and this is derived here from an analysis from the Transform-1 trial comparing sirolimus versus paclitaxel-coated balloon in small vessel disease. And as you can see here on the right-hand side in the PCB arm, there seems to have a nice negative correlation between dissection volume and late lumen loss, suggesting maybe that the more you dissect actually at the end, the more you potentially gain, which is a shift in the paradigm of considering coronary artery dissections as always a cause for bailout stenting. But we have here again to acknowledge that there's no evidence-based IVI criteria established to optimize DCB treatment. When occlusive coronary artery dissection occurs, this is not the end of the world. We have now modification techniques like the one here provided with scoring and cutting balloons, the so-called fenestration technique that can help in releasing the hematoma, causing the flow compromise. And even in completely occlusive lesions here, the technique suggested by our friend Gabriele Gasparini from Milano, the Cutting technique, which combines the inflation of a one-to-one size cutting balloon at the site of the occlusion and the dotted and some movement back and forth, picking movements in order to release the hematoma by fenestrating the intima. When bailout stenting occurs, several trials and tried to identify which are the predictors. As you can see here, DCB-RVD ratio, tortuosity, distal disease, complex lesions, long lesions, as well as de novo, long target lesions, smaller diameters of coated balloons, and shorter inflation times are all associated with the occurrence of bailout stenting. But even if this occurs, we have to be reassured, according to multi-center retrospective studies and a subgroup analysis from the Eastbourne registry, that this is associated with good midterm outcomes. So this is a feasible and safe strategy even when needed. We will probably hear a little bit later about the potential use of bioresorbable scaffold for bailout scaffolding. We have little evidence to date based mainly on case reports. But this is clearly something which is promising, and we can limit the number of stents implanted for DCB failures. So here in a few words, my take-home messages. Coronary dissections are inherent to DCB PCI, and effective strategies to prevent, recognize, and manage them are essential to minimize the need for bailout stenting and expand the adoption of DCB-based PCI. Most coronary dissections are non-flow limiting, ill spontaneously, and can be managed conservatively. Medial dissections may facilitate drug transfer to the vessel wall and have been associated with late positive vessel remodeling and reduced risk of target lesion failure. Scoring balloons and cutting balloons achieve more controlled coronary dissections. This is important for lesion preparation, but they can also safely and effectively modify flow-limiting coronary dissections. And finally, when indicated, bailout stenting after suboptimal DCB PCI is safe and is associated with favorable midterm clinical outcomes. And with that, I would like to thank you for your attention.
Thank you very much.